I'm going to move through this fairly quickly because we've got about an hour to get through this, then we've got an hour through another one. I may be sending you out, if need be, a TED Ed video, which will recap everything I did with you today to kind of hit the highlighted points so you guys are set for the test.
I appreciate that.
So, anytime we're dealing with this, we're dealing basically nervous system, pretty much the two main areas. The central nervous system, which we talked about, and the peripheral nervous system. So we're going to see what they affect, and basically when we're dealing with the central nervous system, we're talking about the brain, the spinal cord, and everything that's associated with that. So the meningeal layers is basically what covers that, and there's 3 layers. You guys are all familiar with those, correct? I don't know if there's going to be diagrams on the test, but this would probably be a good one just to know, as far as knowing kind of the components of the brain, where they are, but more importantly, it's also knowing where the meninges are in comparison to the brain itself. So everything encompassed within the meninges, and these meninges are a consistent layer all around the brain, goes within all the sulcuses and the compartments of the brain, all the way down the spinal cord, all the way covers the cauda equina, which is the horsetail portion, and everything inside of that is considered central nervous system. Everything outside of that, peripheral. So the different layers that we have, the dura mater is the outside. It's going to be your thickest layer, and your pia is going to be your inner layer. It's going to cover it, and it's going to be one of your thinner layers that covers over the brain. And then your arachnoid membrane and arachnoid space is going to be those inter-between, kind of that middle layer, and that's where the cerebral spinal fluid basically is contained. So that's why when we see cerebral spinal fluid out the nose, out the ears, out of something, it means we had to have had a break in the skull itself where it's contained, or within the, spinal cord of something breaking in the bones to cause that area to rupture. Brain takes up majority of the space that's in there. I would just kind of get a good idea of knowing the different aspects of the brain, as far as the cerebrum, the cerebellum, where your brainstem, and kind of talk about those. This part here I'm not too worried about. That when we're talking about the sulcuses and we're talking about the tentorium, basically what they're fibrous layers. I talked about compartment syndromes and how the compartments basically pull the muscles and keep them apart. The tentorium is a fibrous layer inside the brain that keeps the brain portions separated, the two halves of the cerebrum from the cerebellum, and so these are just kind of layers in there, and the sulcuses are different areas in there that I'm not worried about you guys knowing at this point in time. But basically your cerebellum, this is going to be your fine motor control. Your brainstem is going to be your mammalian center. It basically is going to process most of your communication. Your midbrain and your hypothalamus are down in those same locations on the anterior aspect of the spinal cord, basically back into this area, but inside. And those are going to regulate everything from your endocrine process to associated functions, mostly with the endocrine process. And I'm not going to get into you needing to know thalamus, pons, medulla oblongata at this point in time. Just know that your brainstem is your mammalian process, and so if you get intracranial pressure in the brain and it pushes that brainstem down, that shuts down on that area, which is your respiratory drive and your basically main functioning. Brain injuries, basically the biggest thing we worry about with these two is they function at a high metabolic rate. Requires quite a bit of cardiac output, a fair amount of that blood supply to get it up to the brain to feed it. Again, I think I've told you guys before, brain does not store any fat. So the only way it's getting energy is through sugar, basically, coming up from the heart, pumping it back up, and that's how it gets energy. So that's why sugar is going and getting a blood sugar, knowing that is going to be the #1 thing you guys should be testing for any level of consciousness and injuries. It has no other sources to work off of. And it's being fed basically by your carotid artery. There's other basal arteries, but those are your main ones coming in, and your jugulars are your main veins going out. Compression onto those areas can cause functions with the brain, and also you'll be able to see when you have JVD is going to help you diagnose simple processes. And what's going on with the body as well, if you know kind of how that area flows, what would be backed up and what wouldn't be. You don't really need to know about the blood-brain barrier. And I apologize when I go through this quickly, but there's certain things you guys do not need to know that's in here, and I didn't have as much time as I thought. ICP, have you guys talked about this? yet in a lecture? Okay. Joel went over this with you? Okay, so you guys should know that. You should know Cushing's triad, what to be expecting, how to, question?
Cushing's triad, that wasn't,
Did he discuss Cushing's triad with you? Cushing's triad is breathing, blood pressure, and heart rate. And there's a special area.
He explained it as Cushing's
Reflex?
reflex without the regular respiration. So just
Okay, so there's Cushing's triad, is basically how we mostly refer to it. Just to give you an idea from this. So because there's pressure in the brain, that's going to cause pushing down on the brain stem. Works on your mammalian responses, what I said due to your respiratory rates. It's going to affect them. It can decrease them, it can increase them, it's going to make them irregular. That's the biggest thing. So if your patient is breathing irregular, whether it's Cheyne-Stokes or Biot's type breathing or rapid breathing, there's different reasons why you're doing it. It means you have an irregular controlled breathing. Then your blood pressure is going to be what, do you think? It's going to be high because it's backed up. Your force is coming up to the brain. There's too much pressure, so it can't. Your blood pressure is high. What usually happens with your heart rate when the blood pressure is high? Usually up. This is opposite. It can't push up against it, so what happens? That back pressure is going to be going down, pushing into the heart, almost causing like a tamponade, so your heart rate's going to go down. So your breathing is out of control, your blood pressure is up, your heart rate is down. Cushing's triad. And all those things you're going to be able to check out and kind of spec there. The Monroe-Kelly doctrine, I don't think you need to know this, but basically what you need to know is this is a bolt. It's positioned and it's a fixed amount of volume that's in it. Now, that being said, there's volume coming up and there's volume going out, but the volume inside is a fixed amount of it. So, other things that we can do to affect that is we'll talk about hyperventilation in another aspect, and Joel talked about that, of what hyperventilation does. It'll actually decrease, it'll cause cerebral vascular constriction, which will reduce some of the blood flow in there and it'll actually reduce some of that swelling that's inside. But it is a fixed volume. For them, ultimately, anytime you get intracranial pressure in there, usually your end-all treatment on this is surgery. You got to basically either drill into the skull or crack the skull, stop the bleeding that's coming, but you got to have that pressure somewhere to go. And that's why when you get a patient who has skull fracture, they usually don't have ICP because that skull fracture is moved, so they have room for the swelling to go. Make sense? Okay. The cranial nerves, again, I want you guys to know these again. Know what they are, know what they do. So here they are. You may see this in format again because one of the things we're going to do in secondary assessment in history is testing each of these. So what I want you to know, and there's a couple good videos out there which you can just call testing the cranial nerves. You can look up on your own if you don't know these. But I want you to be able to think of, okay, olfactory, number one, how can I test that? Smelling salts. Hope not. Smelling salts. Okay? That's going to be your olfactory. Okay? Smelling on there. 2, optic nerve. Can you see this? You know, you can have people look. You can check not just pupillary reaction on there, but you can check if they can see distances, kind of watch them there. We get it to the ocular motor. How are we going to check that? Well, ocular motor is going to be the movement. So we're going to talk about in secondary assessment doing an H test. One of the things I do with the H test is I have to keep their head straight. Can they move over? Can they look up? Can they look down? Can they come over? Can they go over? And I move my hand in an H, and I'm testing all the motor movements from here of that eye being able to move back and forth. Trigeminal, I didn't go over to abducens, but abducens is also going to be working around the eye itself too. That goes with that whole H pattern. What's that? I mean trochlear. Trochlear is what I meant, sorry. Thank you. Trigeminal. That's the chewing or the mastoid, the mastication muscles. So biting down or chewing, that's going to test that. Your abducens is also going to be associated with there. You're going to get that one. Facial.
Smile?
Touch, feel, smile, grimace, moving. forehead, all this is facial. Mastoid muscles, just think just chewing. Facial is everything else. Acoustic,
Easier.
glossopharyngeal. What's that? Tongue movement. Hypoglossal is really more tongue movement. This is going to be in swallowing and that. And then your vagal nerve will be the other one on there. Can't really test that per se. But that's going to be your control of breathing. You know, people do vagal maneuvers. We're going to talk about in another situation. But the ones that you can test, basically I've told you. I don't want to know those. But know the names. You might see something like a chart and saying, what is cranial nerve number 1? How do you test it? Just fair warning. So that'd be a good slide just to know for know the nerves, or one that shows you testing on there.
Is that for this test on Monday?
Yep.
It's for the one in
Yep.
2 weeks.
Go on Monday.
You may see it in written format. I'm going to leave it at that. I don't know when. When we're dealing with the spine, Joel got to go over this with you pretty good. I don't know how much I should have to go over that. You guys should have a good review of the spine, the spinal column, everything from there. The structure of the vertebral column, everything that's going down. The spinal cord is going to travel down in through that. It's going to go from the brain down to the base of L1 or L2. Can vary from person to person. After L2, it goes into what's called the cauda equina. The spinal cord ends, and after that point in time, it's just nerve fibers. It looks like those plants called the cat tails or horse tails, however you want to call them, that comes down that. And below L2 is where we go in for spinal taps if you're checking for meningitis, because then you won't hit the spinal cord. The spinal cord is surrounded and wrapped. Here's kind of a picture of it here. The spinal cord is wrapped by those meningeal layers all the way down. So the pia mater is directly next to the spinal cord. The dura mater is on the outside, and it's the most outer injury to it, or outer aspect to it. How this cord is basically relayed. What's this surface called? If I'm doing an anatomy, this surface. Anterior ventral, posterior or dorsal. Okay. So when you're looking at this, make sure you know where you're looking at and where you're at. So what you're going to find over here on the what side? Posterior side. This is going to be most of our sensation nerves. These are our sensations coming in. It's a smaller aspect. This area, our gray matter, which gray matter is our neural bodies, is going to be motor. We need more nerves to move muscles and coordination than we do to receive sensation. So that's kind of an easy way to tell. So when I get damage to the front half, I'm dealing with more motor sensation damage, motor activity. Then if I damage the posterior half, I'm dealing with more sensation type issues. So those are kind of things we'll talk about, some spinal cord injuries as well. I'm not worried about you guys knowing the pathways coming up and that. It's just the white matter that's in there is all the spinal pathways, and that's the axons and dendrites that are going up. But the spinal protection right here is a good slide that just shows you how that area is wrapped. And just think of that meningeal barrier is the same around the entire brain and surrounds everything coming in the same order. Off of the spinal cord, as it comes down, the peripheral nerves will come off those into nerve roots. And they'll branch out on each side, and in those nerve roots and those pairs that come out, they're labeled basically as they come out from each of the vertebrae themselves. They're going to have motor and sensation on each of the branches that comes out. And they come out into areas that are also called plexuses. We have we have nerve plexuses like in the axillary region, different spots that come in and they combine and work together. When you guys are going on December 14th to the bodies exhibit, you're going to see a lot of these nerve plexuses. They did a good job of dissecting them out. Dermatomes, you guys did get the dermatome map, you said? If not, Google it, kind of know where it is, know some major landmarks on there. So if we said this part of your body can't move, where is the level of the nerve injury? Some good ones to know, T4, T10, L1 through 4 and S1 and 2. I want to know where those are.
Oh,
If you could-
what?
L1 through 4, S1 and 2.
Start at the top. 2-4.
210.
And
L1 through 4, S1 and 2. Just kind of know where those are at. Those are some major landmark areas that I would know. Spinal reflex stuff I kind of already told you about. It's basically, those are just where you have reaction is quick. You touch a hot plate, doesn't have to go to the brain to pull it away. It'll immediately pull it away and get a reaction. You guys have done pretty much your parasympathetic, sympathetic nervous system. Already talked about it. I don't remember there being any follow-up questions on this. Those are just basically, think of those as your fight and flight and your feed and breed type of reactions. Your sympathetic is your fight and flight. Your parasympathetic is your feed and breed. Different types of brain injuries are going to come in there. You can have a direct injury coming straight to the brain. Anytime that you get a direct injury like this and you get a rapid acceleration or deceleration to the brain itself, you get penetrating trauma, anything that functions those nerve cells that can come in. It'll disrupt the blood vessels, damage the brain itself moving around in the cavity. Any type of these type of injuries directly on there can cause those direct brain injuries, and that's again a focal head direct to the brain itself, and a direct injury. Those also count for the contra Q injuries. So, direct injury, you get the rock thrown to the head, causes basically the brain to smack in the back of the head, and then the brain moves and comes and smacks into the front of the head as well. So you get two injury sites to the brain. You get the direct impact, and then you'll get the brain moving and kind of moving with inside that. That's your direct trauma. And with any direct injury, the big thing you're going to be looking about is any bleeding that can come in there. And have they talked to you much about epidural and subdural bleeds yet?
Yeah.
Joel went over those? Okay. So know which one's venous, which one's arterial, know sensation, basically a level of consciousness, which one affects which. One of them, you pretty much lose consciousness pretty quick, very serious, and you're out. One of them may take a day, 24, 48 hours to knock you out completely. You guys know which one those are? Yes?
Let the girls pronounce the girls well.
you said one was vein and one was arterial? I'm sure it's not.
What's that?
I'm sure it's not.
Okay. So, when we have in those any direction, subdural hematoma is basically bleeding in the subarachnoid space. How long does this one take to set in? Slow. This is your venous bleed. This can take over a period of time. It's got some room for the blood to move around, and that blood seeps in slowly. And so you could be, this is Liam Neeson's wife and Sonny Bono, both involved in skiing accidents, got concussions, were fine, went home, died in their sleep the next day. Subdural slow bleeds. Whereas an epidural bleed is an arterial bleed, and because it's arterial and it's pulsating and pushing in faster, and where it is and pushes on the brain quicker, you get loss of conscious quicker. Other things you can get is you can get diffuse injuries on there. These are basically when you get concussions, and as we're finding out more and more, concussions can be very, very serious injuries. It can cause permanent damage eventually too, especially if there are multiple concussions over a short period of time. So we've had a lot of change because of diagnosing these and seeing what can happen to them. And we'll be talking about concussions also in another area as well. And I apologize if I'm going through these quick, it's because I'm trying to hit the stuff that's I know important. So if I'm skipping over something, you take it as a will. I'm not saying you're not going to see it on the test, but I'm not saying you're going to see it on the test. Here's kind of the aspect when we talked about, and Joel was probably talking about this with Cushing's reflex, and it depends on where you're getting the pressure on there, but basically you will get different type of breathing patterns based on the type of injury that's coming up. and where you're pushing on the brainstem, where the injuries are going to be affected on there. So just with that Cushing's triad, it's any type of disordered control of breathing. Whether it's Cheyne-Stokes, whether it's Biot's type breathing, everything from there, it's just going to be a disordered control of breathing. And here it is talking about Cushing's triad again, combination of increasing blood pressure, decreased heart rate, and irregular respirations. I've said that multiple times, so it must be important, right? Okay. Pediatric trauma on there, not going to get into too much of it. The nice thing for them is basically the fontanelles are not fused yet, so they have room for swelling, for that to move. They are really cartilaginous in most of the cases, and a lot of times you don't see too many skull fractures in pediatrics. You can. If you do, then you're going to be highly susceptible also of child abuse. Can happen in other cases, but you're just more highly susceptible to it. There's different type of spinal cord injuries that are out there. You can get a concussion to the spinal cord, which is just the same as we get a concussion to the brain. It's a temporary type of injury. It's transient, it comes in, it gets basically a blunt trauma, the body has to heal itself, so it's out for a period of time, comes right back. A contusion is the same type of thing, but it's actually you're getting more tissue damage associated with it. There's some bleeding in there that can happen to it. It takes a little bit longer to repair itself, but a contusion and a concussion are going to be temporary type of events where you can get loss of sensation, loss of motor function, but they will heal themselves and they will come back. When we talk about compression, or what's called neuropraxia, that's a different story. That compression can cause anything from a transient type of response to, if it's compressed in the too much pressure for too long, it can cause permanent damage. So it can basically decrease the blood flow there and it kills it off. It can return. Sometimes it can be permanent damage. So out of your injuries, obviously if we're dealing with like a laceration or a transection, those are worse. But out of concussion, contusion, compression is your most serious injury to the spinal cord of those three. Your most serious injuries obviously are lacerations, transections, and those. Anytime we get a laceration or a break to those spinal cords, most of those times those can be permanent damage. And so we'll talk about a couple syndromes here of determining on where it is as far as the level and what's being affected. So I talked to you in that picture there and told you where sensation is at and where motor's at, right? So if I tell you you've got a loss of motor sensation on the left side, where do you have damage to? Not on the spinal cord.
Right.
Left side of the spinal cord, whereabouts? So if it's on the, okay, let me just do again. So I get a knife wound to my spine, somewhere in my back, and on this side I've lost motor function to this side, my right side.
Anterior right.
Anterior right, because remember the anterior aspect of the spinal cord is motor, the posterior side is sensation. If I lose motor sensation and motor and sensation to the right side, where's my injury? The whole right side. I'm affecting the whole right side. So those different aspects that you can kind of tell what it is. Oh, I can feel you. I can feel you touching. I can tell it's a touch. I can tell it's a brush, but I can't move it. Okay, it lets me know the anterior cord is what's affected. You can get bleeding from these areas. You can get stretching disruption. I'm sure Joel talked to you about all the type of spinal injuries and what it can do and how it affects. Hyperflexion, hyperextension, and then loss of blood supply as well. You can also get transections of the spinal cord, basically where you can sever it completely. You can get partial damage to it. If we do sever the cord completely, depending on where it happens, is how we classify a person by their disability. What I mean by that is if I transect the cord below C3, but say above, right around C7, where's C7 on my dermatome, do you think? about right in here. So I'm going to be a quad. I'm going to be a quadriplegic. I'm going to lose all 4 appendages. If I'm below T4, where do you think T4 is at? Nipple line. Where do you think my paralysis or my condition is going to be? Then I'm going to be a paraplegic because it's going to be below because my arms are above T4, right? And if I'm up in C1 through C3, that's actually going to affect my breathing. That's Christopher Reeve syndrome. You all know Superman. That's putting on a vent and everything else. So you can kind of tell different things. We're also, did Dr. Dirks talk to you about spinal nerve shock
No.
and
Vaguely.
transections of the cord? So there'd be basically when you get a damage to the nerves themselves, nerves are controlling your body systems, right? Nerves control your arteries and vessels. And if you go into neurogenic shock
Yeah.
because of a spinal transection, you're going to have a delineated line potentially where you're going to be pink and warm below the injury and you may be blue above. And you guys know why?
Dilated vessels below.
Vessels dilated below because the body's not able to regulate and close those off to shunt to the core from the injury. So it violates and it basically fills out, and so you get nice and warm out the core. Whereas up in top, your sympathetics and parasympathetic systems are still working, your nerves are working. It's shunting all the information to get blood back to the core, so you're blue above. But when you'll see that delineation, you'll be able to tell exactly, if you know your dermatomes, the level of that injury. And those talk about the phases. So, one of the things that are out there as far as spinal cord injuries is you can have what's called an anterior cord syndrome. Or basically, you get some impingement of the bony fragments and pressures onto the arteries. So, it's a loss of blood flow to the anterior cord is what's called an anterior cord syndrome. So, it's loss of blood flow. It doesn't have to be dealing with damage or trauma or anything like that, but it's bony impingements that do on there. You get what's called anterior cord syndrome. And anterior cord affects what? Motor. And I talked to you a little bit about getting one side. If I get stabbed on one side, well, that's what's called Brown-Séquard syndrome. This is a penetrating injury that affects one side of the cord. What you're going to see is on the side that's affected, I'm going to lose my motor function and my sensation because it got anterior and posterior aspect of the cord, right? It will actually cause some decrease in sensation on the contralateral side as well.
So if you get hurt on the left side, it's going to affect the left side. So what's the reflex part? Because I'm seeing that, maybe I'm misunderstanding it, because it looks like they're...
You're talking about the crossing in the central nervous system that happens
Okay,
up
so
in the
that's-
brain.
Oh,
So
yeah.
if we're dealing with a central nervous system, this is dealing with the peripheral portions coming out of the spinal cord.
Gotcha. So once it comes out, left is left, right is right.
Yep, so the actual crossing is up in the brain, above the brain stem before it turns in the spinal cord. So if you get damage to your right side of the brain, it'll affect the left side of your body. So that's what central nervous system, traumatic brain injuries can affect contralateral side. Once you get into the spinal cord, it's ipsilateral side. Ipsilateral, same side, contralateral, opposite side. So Brown-Séquard syndrome, I would know anterior cord as well. Brown-Séquard syndrome is basically penetrating trauma to one side or one hemisphere of the spinal cord, causes loss of motor and sensation on that same side as the injury, and it'll lose some loss of sensation on the opposite side. Spinal shock, again, this is a temporary shock. This doesn't have to be like neurogenic shock. It can be in there. But neurogenic shock we went over, so you guys have that down, correct? Okay. Or you have notes or something to go to on that. Other type of injuries you can have are transient injuries that come in. Stingers, if you ever had this, is that shooting neck pain that can come in. It's a transient injury. There it's dealing from swelling that's popping up in there. That is an indication you can use ice for. That's the one. It's not an orthopedic, that's a nerve injury and it's swelling specific on that. But stingers are transient injuries. They don't even have to do that. A lot of times rest and that is going to come out there. And then you can have a transient quadriplegic accident where basically you are getting some swelling or compression on the spinal cord below the level of C3, because that's where your breathing is, that can actually cause you to be temporary paralysis. And it does return. Injuries can cause anywhere along the pathway. This is why we have the dermatome maps, so that based on those sensation patterns, you can figure out where they're injured at. So if I have loss of sensation in my calf, where's the level of my spinal cord damage? On my calf.
That's
S.
no,
Should be S2. Is it S1 coming up
It
there?
goes all the way down. If you look at the
You
map.
see your
it
calf?
says
I don't have my
S1.
map in front of me.
It's L4,
That's
this is
one.
the calf.
It shows all three of them.
Well, in the book, it shows the calf, posterior calf being L1, or S1 and S2.
Yeah. S1 and S2.
Stupid.
I thought it was S2, depending on if I'm doing inside or outside.
There's also another chart on page 200. It shows
So page 292,
Look at 300 though, because it says something totally.
because L3, 4 come down the front and 5, and they're on the top of the foot. S1 and S2 come up the back of the leg.
S's are green. L's are green.
Is S2 not the anal link also?
S2, I believe, also goes up there. S2 would be the medial portion that comes right up and hits that area, but it'll extend all the way down, the back of the leg along the hamstrings, down to the calf and soleus. Yes, S2 does do the anal.
Yeah, I just want to make sure I know what I'm testing.
Please just don't wink at me though.
I don't think you're gonna have to work the belly.
I want you to draw the picture.
Yeah.
Parts of this.
Pediatric patients, because of the way their spinal column is, they can cause stretching injuries. They're pretty resilient as far as those areas go, but definitely can have injuries. Biggest thing we want to do with any nerve injury is doing the mechanism injury. How did this happen? What potentially could have happened? What was there a shearing force? Was there a bending force? Where was it at? So we're going to be assessing all those type of things. Why do we do C-collar?
So
To remind the patient not to
patient not to move?
Absolutely. The C-collar is to remind them to not move. It's basically, that doesn't do the spinal restrictions itself. And the reason that we're doing this is because the cerebral, if you look at all the vertebral bodies, the cerebral, some of them don't have vertebral bodies, right? But it's the most narrow aspect, and it's the most sensitive aspect of the spinal cord, where we can get the most amount of injuries to, and those injuries are going to be more traumatic than an injury, say, in the lumbar region. So that's why we're more protective of those areas. But again, the C-collar is mostly just to remind the patient not to move their head. So obviously you guys know this, I don't need to really cover about C-spine precautions. Checking out their motor functions. Have you guys gone to Glasgow Coma scales yet? Okay. Glasgow Coma scales, we'll get into those because you guys are going to have to be able to assess those areas. For right now, it's basically assessing their level of consciousness. How are they responding? Are they able to maintain their airway or not? And those are going to make determinations of how they're breathing and whether we need to take their airway or how we're going to manage their airway for them. You guys will get into capnography because I'm assuming you guys have not done waveform capnography yet. Okay. So I'm not going to get over that, but all those type of things are going to affect how the breathing is going and how it comes into. Again, herniation of the brain is going to cause basically swelling with inside. It's going to push that brain stem down through the foramen magnum and cause altered breathing functions, and different posturing can be there as well. We have two types of posturing that we'll talk about in there, and that's decorticate and decerebrate. And if you get decerebrate posturing, that's probably the worst neurological stimulation that's out there. And if you go through your Glasgow Coma scale, you'll see as you're coming down, that puts you at a 2 for function as opposed to a 1, which is basically makes our dead patient as 3, right? For assessment. So we'll do our rapid trauma assessment. We're basically going to be assessing the head for damage to the skull. We're going to be checking the eyes. We're going to be checking all type of reactions with that. We're going to be checking the neck We're doing that. We're looking for step-off fractures, deformities, any type of things, but we're also working on the mechanism injury to see where it comes to. We're going to see how the eye reacts to it when we do the pen light, and we're going to see if that helps us determine any type of brain injuries. Or sometimes it's a brain injury, sometimes it's medication. Same thing affecting the central nervous system. The eyes are going to be basically a good indicator for us for underlying injuries and damage that we got to be looking for. Spinal cord injuries, again, we're going to be looking for loss of motor sensation control below the level of the injury. And then if certain traumas that'll come in there, there'll be a definite line where it'll come into, and those dermatomes are pretty good about that, to where if you've lost sensation, you'll lose sensation along that whole area and down distal from that spot that's a spinal cord affected. If it's just the peripheral area, you can lose it to just one aspect of just the dermatome, and it's a peripheral. But if it's damage to the spinal cord, you're going to lose it not only to that dermatome, but every dermatome below it. That's how we're going to also check out motor sensation and everything as well. This is, again, also what we're doing for grip strength, for strokes and that, because this is what's going to happen with injuries in the brain and everything too, where you get unilateral. But it'll also be for spinal cord we're checking as well. You want to check movement, strength, always bilateral on the hands and the feet, because you can tell exactly how they're doing it. And we're basically just looking for that. Loss of motor function, loss of sensation, numbness, tingling, pain out of proportion. I'm going to kind of skip through this because that's going to be we're going to talk about patient assessment later. We're going to test for a Babinski sign, where we're basically going and running this up the bottom of the foot, and we're looking for a reaction. If we're not getting a reaction, that is a bad sign. But it's opposite in kids. Kids are going to talk about pulling away versus squeezing in. Pediatrics respond to a Babinski different than adults do. And then obviously we're going to be monitoring their ICP based on what? We're going to be monitoring whether they have intracranial pressure based on what? Vitals, which vitals specifically?
Blood pressure?
Cushing's triad, blood pressure, heart rate, and breathing.
On the Babinski sign, I wrote down in my notes that pulling away the toes was a bad thing, based on Dr. Leakey's lecture yesterday.
Was he referring to the pediatrics?
No, he just
She
said
said in adults.
any sort of flexion in the toes instead of
I thought he was talking about.
clenching
He was
down.
talking about peds, I thought.
Yeah.
Was he?
I think that's peds, because peds, as you pull away, it's bad. Squeezing in is good. Adults, it's the reaction is good sign. Not reacting is a bad. So I'm pretty sure he's talking about pediatric.
Okay.
Because pediatric, they'll respond, and if they pull away, it's bad. If they toes flex towards, it's a good sign. But adults, if they don't move or they move.
Is there a cutoff for that? Adult feet? Is there like a 16-year-old cutoff?
No, usually we're talking puberty. And puberty changes. Sometimes we say 8, sometimes we say 6, sometimes we say 10. Just varies. More when we're doing pediatrics for Babinski, I'm thinking more 3. Young. Kids, infants. All right, so yeah, we're monitoring those vitals, always looking through. I don't know if you guys see a constant path about Cushing's triad coming in here, so saying I keep seeing it a lot. Glasgow Coma Scale, again, we'll be doing this evaluation. You guys are going to get really good at this because you guys are going to be including it in all your PCRs once you're out in practice, because Joe wants those. For every area you're going is getting the patient's GCS. And we're going to go through a skill sheet for each of those. Other things we're looking for is patients' ability to maintain their position of the arm, and for male patients dealing with priapism. Priapism is basically anytime we get damage to the spinal cord, again, below a certain level, which was the genitalia at? Yeah. It's basically below a certain area there. It's going to cause uncontrolled vasodilation. And so that's a sign for, at least in males, for any spinal injuries, and be looking for that.
Doctor saying that was a specific C-spine injury?
Yeah, that'll actually pop that in. as with any questions, again, we're going to talk about sample, reassessing your patient. Anytime you have any serious nerve injuries, you want to be constantly reassessing, reevaluating every 5 minutes on this. With vitals, you're going to be looking a lot before there, but you're going to keep checking their sensation, motor function to see if this is a transient event or if this is a permanent type function. I don't think I need to talk to you guys about spinal, seated immobilization. RSI, have you guys gone through this yet? I know we're using the term OSI, but it's still a rapid sequence intubation, but we do it an optimized rapid sequel intubation because we're doing it with oxygen.
That's the first time we've heard that.
First time you've heard optimal?
Yeah.
Okay, so we use the term now, and we're supposed to use the term OSI instead of RSI, optimal sequence intubation. And what we're doing is because of, there's always a group of anesthesiologists who's trying to take away the ability to intubate from paramedics. And they're saying that we have a problem of losing the oxygen saturation with our patients. So what we are doing to prevent that now is we are actually putting a nasal cannula into our patient that we're running at 2, 4, 6 liters while we have our patient, we're getting ready. Once they are, and the reason we do that is for discomfort. Causes drying in the nasal cavity, but over 6 they can't tolerate it anyway. Once we've sedated our patient and we paralyze our patient, then we can turn that up to 20 liters, 15 liters, wherever. We can put it in the mouth directly or we can leave it in the nose. And that's giving us passive oxygenation to keep our saturation levels up while we're taking the time to put in our blade, see our position, and get it in. So that's why it's optimal, is because we've always got oxygen flowing. That's the difference. But it's still rapid sequence intubation of where we are sedating our patient, we're paralyzing our patient, and then we are pushing other medications based on, do we have a head injury, do we have a pediatric patient? Because there are drugs that sometimes we'll do, including lidocaine and atropine. So if you guys have not gone over those medications and that yet, then you won't be tested on. Different things that we can do for seizure disorders. Diazepam. Diazepam is probably one of the more common ones you guys are going to see out there. And what do you think is the most common form you're going to see this in?
For seizure patients?
What kind of pills?
Are they
Not for seizure. You're actually, yeah, the white pill is actually really common. I had to give it to my wife several times before she could figure it right.
Is it
Rectal.
Yeah, because we have a
It's going
little
to come in
boy.
a suppository. Usually they come in 10 milligrams, which is a huge dose. Come in 5 milligram and 10 milligram suppositories. Why? Because are you going to give a pill to someone in seizing? No. So you'll have to give it through suppositories. But you're right. The most common way you're going to find Valium is in pill form. You are correct in that. But for seizure, you're going to find it in suppositories. And actually on Medic 42, we carry one specifically for a patient in the area. In case she is somewhere not at home and doesn't have her medication. So that's going to be the fastest way so you can give it in 7 minutes. We don't usually use that for seizures. What do we use for seizures? Versed. So Versed is usually what's used in Spokane County. I still have lorazepam up at District 4. I do not have it at District 8. I don't think you guys have it in the city, but I'm not sure. AMR carries it, right? So I love lorazepam. It works probably the best for seizures. Works better than others for me. So anyways, anytime you get the seizure activities, we want to stop it. Other medications that are going to affect the central nervous system, obviously, are any of our level 2 narcotics and some level 3s in there. So we use morphine for pain. We'll talk about morphine when you guys get your drug protocols, why we do it for hypovolemic states and what it does to the body versus fentanyl and different times we can use it. Ketamine is another fantastic drug that's out there. Idaho has that. We don't have it in Washington State yet. It's realistically used initially as a tranquilizer for animals, but it works great for conscious sedation. We can't do conscious sedation in Spokane County, or not supposed to, but if we were sedating our patient and using fentanyl for pain management, and if we say the right words, we can do conscious sedation in Spokane County. You just got to know how to use the terminology. Joel will teach you that one. I'm not going to do that. But ketamine is a fantastic analgesic that comes in, and I hope we get it in there too. Mannitol is another one we don't have. Mannitol is one of the medications we use for crush injuries. And I'll talk about that. There are 5 main medications in my mind that I will use for a crush injury that are all indicated. Typically, we carry 2 or 3 in Spokane County is all we're given. And you guys got a little intro into that? No, of the medications for crush.
Sodium bicarb.
Albuterol. You guys got albuterol, right? Albuterol is one of them.
No, we didn't go through.
Sodium bicarb and, we talked about albuterol.
Okay, did you talk about it for crush?
But it was brief, it was
Yeah.
brief though.
Okay, so you guys will get it, but there are 5 main medications in my mind that work fantastic for clearing out for crush syndrome. Dextrose is obviously going to be the biggest thing. Why? For brain injuries or nerve injuries?
Sugar.
Sugar. Because there's no fat stores and this is their own energy aspect. So,
But doesn't that increase the pressure in the brain?
sugar?
Yeah. Like
It basically, if you're going to talk osmotic principles, yes, but you can use sugar to certain extents on there if basically you're trying to determine conscious of unknown origin. So when I talk brain injury, it can be from several different things. It doesn't have to be traumatic brain injury. It can be chemical brain injury or other aspects too. And then we'll consider what we're going to have to do to manage that person's pain between medications, between which paralytic agents. You guys probably have not gone over depolarizing versus polarizing agents yet.
Yes, we have.
Have you? Perfect. Okay, so you guys have all gone through those? Fantastic, okay. Apologize, I don't get to see what you guys are going through all the time, so. So those are kind of basically the areas that we're looking at as far as trauma and damage there. So that's all I got for you on this one. Like I said, I think there's some more stuff. I really would like to have gone more in depth on this with you, but I'm kind of limited there, so I will make a TED Ed today, and I'll send it out to you. I'm going to videotape basically my screen, and I'm going to just whip through these slides so I can do it really fast, and I'll send it out to you, hitting the highlighted points I think you guys should know. It may take me about a half hour to do it, but you're going to see me whipping through slides because I'm going to try and go just to the important slides. Fair enough? Okay.
Thank you.
10-minute break unless there's